What's the benefit of TPA? Well, it's very time-driven. The sooner you give it, the better the benefit. Giving TPA at 1 hour is better than at 2 hours. It's better at 2 hours than 3 hours, and better at 3 hours than 4.5 hours. The benefits decline over time, so the door-to-needle time, the door-to-treatment time, and all of the individual time elements within that have to be fine-tuned so these patients are fast-tracked. We can't do much about how long it took them to get to our hospital other than public awareness, but we do have control over what happens once they arrive at our emergency department, and those various time elements have to be addressed and critically analyzed in all hospitals. The absolute benefits from TPA range from 11 to 13% in real terms, and this is for complete cure. So it's a very high benchmark that this study set. It was a complete cure. So 11 to 13% in absolute terms, 55% in relative terms. And I can assure you that if any treatment for cancer, AIDS, heart attack, or any disease like that came along and demonstrated an 11% absolute benefit, it would be hailed as a miracle or a breakthrough, and it's certainly true for stroke, but it's perhaps been underappreciated. 2 years ago, the therapeutic window was expanded based on the ECAS-3 trial, a very large, well-conducted trial, which demonstrated that the benefits of TPA extended from not only to 3 hours, but as late as 4.5 hours. This is not a reason to delay therapy to 4.5 hours, but it does allow some patients arriving later in the course of their stroke symptoms to also get treatment and get benefit from treatment. And this graph demonstrates the benefits of TPA running down over time. And for the majority of patients, the therapeutic window for standard IV TPA runs out at about 4.5 hours. But as you can see from this graph, the benefits are greatest, at 60 minutes, and minute by minute brain cells die. And you've probably seen the heart and stroke ad where every minute 2 million more brain cells die as a result of your acute stroke as it evolves. And so I'm sure if you were the individual on the stretcher, you'd sooner be treated here than here. This is the demonstration of the ECAS benefits to this extended 3 to 4.5 hour window. It's a bit of a busy slide and a busy graph, but there was a pooled analysis of all prior TPA studies showing projected absolute benefit of about 5% in these patients treated between 3 and 4.5 hours. And when the actual study was done, it demonstrated that the benefits within this late therapeutic window were actually even a little bit greater than projected, an absolute benefit of 7%. So not as great as if you're treating the patients early on, but still a very real benefit. And I would note at no cost at the back end of stroke care. This is the modified Rankin score. So 6 is death. 5 is bedridden and severely disabled. These are horrible outcomes, and you can see there was no increase in the overall incidence of death or severe disability, but there were benefits along the way. If you actually look at, this is again a cure trial, so in order to be deemed to be an effective TPA therapy, you had to have a virtual cure, modified Rankin score of 0 or 1. But we actually recognize that many patients who get TPA, especially in the late therapeutic window, may not have a complete cure, but they get partial benefit from it. And the numbers needed to treat in this expanded window to get some benefit is still very acceptable, less than 6. So what are the care requirements for TPA? Well, you need an organized emergency system, of course, to triage and evaluate the patient. This falls on the emergency department staff, nursing staff, triage staff, and the frontline physicians, who are the emergency physicians, of course. And then there are standard assessments that have to be undertaken, vital signs, blood sugar, some routine lab work, neurovitals. And then, of course, the whole thing hinges then on clinical features and the results of a CT scan. And for most patients, in most emergency departments, a CT scan is the highest priority patient for the CT scanner. They should be the next patient on the table, regardless of what else is going on and what other booked or pre-booked procedures might be going on. This disease is so time critical that the patient should be on the scanner next. And that should happen immediately, and you should do everything to make that happen, including pushing the patient to the CT yourself, not waiting for porters and so on. Once the decision is made, then there's a consultation process. There's most typically a handoff between the emergency physician and whoever is going to assume that the ongoing care for the patient and the administration of TPA, but this is site-specific and should be worked out at each hospital. And then following the TPA delivery, there is a standard set of orders that are given. Patients do require close monitoring of neurovital signs, good bedside care, good control of blood pressure. And those treatments are all very well standardized and available to all sites. So what actually happens with telestroke? Well, this is the sending site, the emergency physician, the patient, the screen, and this is actually Frank Silver. This is a colleague of Andrew's and mine who is actually in Toronto here at the other end of this consultation process. So he's got the CAT scan up on one screen, the patient and the physician embedded here in the screen. He sees the patient and the CT scan and the emergency department staff. From this end, the patient and the emergency staff sees the consultant. And it's a lot more intimate than you think it might be. I've been quite impressed that when you zoom in the cameras and you talk to the spouse and the physician and you see the patient, you do a neurological exam, the resolution is superb, and the consultation is a meaningful face-to-face consultation. So where do we stand right now in BC? We have 2 small telestroke programs in place. Of course, the hope is to expand that throughout the province on a provincial-wide basis, but we have a telestroke system based in Victoria, currently serving Cowichan and Nanaimo, and we have a telestroke system based at Vancouver General Hospital in Vancouver, servicing Chilliwack and Peace Arch. And the process is that the site identifies a potential patient, they activate the telestroke system, and we can go into that. The initial contact is usually by phone, but then if things are a go, you then move on to a direct live video link. Images are reviewed at the consulting site, because usually there is a strong need to ensure that the CT is eligible, as well as the clinical features. And so we've been able to do this very effectively at these 4 sites that we now have up and running in British Columbia.